Diagnosis of acute dislocation. We have radiological finding, anteroposterior and lateral radiological finding. Of course, elbow, anteroposterior and lateral view to see the humeral articulation and its relation to each other. Assessment of instability through range of motion. This is very important. Of course, we have all the emergency hospital, the patient coming to us with a dislocated elbow. Firstly, we relocate the elbow. And after the relocation, I have to test the range of motion from 0 to 130, I mean through the whole full range of motion. And to see if there is a instability occurs through or not. If it's completely unstable, and this is the algorithm also written in the American Academy, you will see that the patient can be not only in this state for 7 days, and then after 7 days I have to get range of motion. There's nothing to get. However, if the patient is unstable through one of the steps or one of the degrees, 30 to 45 degrees, this is a meaning. 90 degrees or more, this it has another meaning according to the affected ligament and the same thing. So assessment of instability through range of motion, and then if it's unstable, I have to test for varus and valgus. Which part of the ligaments are torn? Is it varus or valgus? To test for varus instability, I have to make full pronation of valgus, to make the humeral, to make the radius and ulna to be looked over the lateral collateral ligament, and to make only the anterior medial collateral ligament as a hinge. Again, in Arabic. لو أنا عملت عشان أعرف أجيب الفالجس ستريس تيست، أنا ممكن دلوقتي العيان ده يكون عنده، أنا عايز أفحص إيه دلوقتي اللي هو الميديال كولاteral ligament، هستخدمه كهنج، فلازم ما يكونش عندي لاترال، يعني اللاترال يكون بلوكد كأنه سليم حتى لو هو مقطوع، فهعمل فول برونيشن اوف ذا فور ارم وحافظ على الهيومرس في مكانه، وبالتالي كده أنا بلوك اللاترال كولاteral ligament وبتست بس الميديال كولاteral ligament، تمام؟ بينما لو هعمل if I'm going to make the varus, I have to make internal rotation over the shoulder. Internal rotation over the shoulder of the humerus. And then test for the varus. So I'm testing varus and valgus. Okay? In this condition, both examination, for the examination should be done in full flexion and 30 degree. Why? Because in 30 degree flexion, I eliminate the effect of the olecranon. The olecranon acts as a secondary stabilizing factor in full extension. So when I'm doing 30 degree, I eliminate the effect of the olecranon, and I can test both of them. Last, stress view X-ray. To make stress X-ray view to see if there is difference in the patient with post-collateral instability, if there is difference in the difference in extension or inflection with stress or what. You see what's called widening or dropping sound. According to the diagnosis of post-collateral instability, in this condition there will be, as we said before, there will be external rotation of the radius and ulna in relation to the distal humerus. They should be differentiated from the radio-ulnar dissociation. Okay, with the superior ulnar joint. In the superior ulnar joint, the radius only will lose the articulation with the humerus. Okay, so there is radiocapitular affection with radio-ulnar. In here, both of them lost the articulation with the humerus because they both external rotate. What are the symptoms the patient come with us? The patient with post-collateral instability will not come dislocated. This is a patient dislocated and went to reduced and went to home, and then after doing his work, he has some symptoms. He will complain of. What are the symptoms? First, whole variable presentation. Not only patient coming with pain, some of them have clicking or popping, snapping. Will have history of trauma or surgery. This is important because in the history I have to understand or to know or to search for the cause of the instability. What's the cause of post-collateral instability? The most common cause we know is dislocation, but we have other causes. Other causes include, first of all, patient with doing surgery, like lateral humeral condyle. If we violate for the lateral collateral ligament going distally and complete stripping of the soft tissue over the lateral aspect and violating the common extensor origin, this will result in post-collateral instability. Also, the patient doing tennis elbow release. Of course, in tennis elbow, I have to attack the extensor cardialis brevis. Some of them will make complete devastation of the lateral collateral ligament. The patient come with post-collateral instability. So this is what's called iatrogenic post-collateral instability. We have the patient with chronic cubitus varus, the patient with chronic carrying, chronic carriers, the patient with chronic connective tissue disease like Ehlers-Danlos. We have to test for post-collateral instability. What are the signs? The signs here are the test we have to do. The lateral pivot shift. التست دي احنا هنقولها في الاخر هنعملها مع بعض. Lateral pivot shift. This is the test. This is what's called the O'Driscoll test. O'Driscoll, you can consider him the father of post-collateral instability. The first one who spoke about and make classification in 1991, and he is the one who examined this lateral pivot shift. How to make the patient will lie on the supine, on the operating table, okay, and we will grasp the forearm. We'll grasp the forearm, making the supination, and make axial force and valgus. The other hand is grasping the radial collateral or radial side and the radial head. And beginning from extension, going to flexion. It's the same as the pivot shift to the knee. Okay? Going from flexion to extension. The maximum degree of instability will occur at the flexion 40 degrees. And then, with completing the flexion, reduction will occur at the level of the elbow joint. So clicking will occur. However, the patient with the lateral pivot shift, without general anesthesia, you shouldn't consider him that you will be clicking and pulling as you think, just only apprehension, like the patient with abduction, external rotation of the shoulder of elbow instability. So it's considered to be elbow apprehension test more than instability, except if we don't under anesthesia. The second one is the lateral rotator, the drawer test. It's the same. Make the elbow in full pronation to make the radius coming posteriorly, and making backward, drawing backward the forearm in relation to the humerus, in relation to the elbow. If the patient with the posterolateral instability, it will go posterior. We have other signs, easy signs to be done in the clinic. The one is table top relocation test. How can we do? Ask the patient to put his hands on the table, okay, and ask him to elevate himself on the table using his hand without using any aid. The other one is active floor push-up sign. الحين العين يلعب ضغط. And ask the patient to make this position, and the patient with the posterolateral instability, pain, and sometimes clicking and moving will occur. Chair sign. Ask the patient to sit on the chair and ask him to raise himself with use of the elbow, with the use of his hands only, without use of any other joints or his back. Just using his hand to elevate himself. All these will result in reduction of pain or reduction of clicking or popping, or even sometimes dislocation, which is notable at this area. Radiologically, X-ray is the most important of course. The X-ray for presence of associated fracture. If the present elbow instability alone is considered to be single instability. If you have associated fracture, this is another injury which is called complex instability. For the presence of impression fracture, in case of the puncture dislocation, the chronoid may make impression of the distal humerus, or the reverse. The tropic sign of the elbow. If I see 4 mm wideness in comparison to the other side, this is an indicative posterolateral instability. And we can make pivot shift. This is what's called dynamic instability. Making a pivot shift with imaging under CR to see if there's the presence of instability. MRI is of little value. We have another diagnostic entity, which is arthroscopic diagnosis, to show widening of the lateral edge of the elbow with elongation of the lateral elbow. At last, we have to know that the posterolateral instability is a clinical diagnosis. Okay, this is an X-ray showing widening of the lateral X-ray, widening 4 mm widening, or what's called the dropping sign. There is no associated fracture here. And this is an MRI showing presence of the fluid sign with the presence of disruption of the lateral collateral. How to manage the posterolateral instability? The key here is to regain the function of the lateral collateral ligament, lateral ulnar collateral ligament. It may be done even with, as we said before, repair or reconstruction. Repair is not of good value or not good examination. First of all, correction of the bony element. Okay. Secondly, surgical repair. In acute cases, why it's not good result? Because most of the cases not disrupted mid-substance, usually avulsed. So it's better to make reconstruction with the use of other tendon like CVT or even the palmaris rather than actual repair. Recently, we have the arthroscopically assisted elbow examination, and then reconstruction with electrothermal changes. This is a method of reconstruction using palmaris bones. What about complex instability? This was before posterolateral. The complex instability